It's now time. Thank you everyone for coming to this webinar. I think we have got an excellent program, exciting talks. It gives me a great honor to introduce Dr. Satish Krishnamurthy. Dr. Krishnamurthy is Professor of Neurosurgery at State University of New York in Syracuse. He's a former interim chair of the department. He has a wealth of experience and also very active in hydrocephalus research. So without further ado, Dr. Krishnamurthy, may I invite you to give your lecture. Thank you, sir.
Thank you so much, Naren. I sincerely appreciate your invitation to present at this webinar to the international audience. I'm going to talk about commonly used medications associated with risk of hydrocephalus. Our concept prior to investigating this as a background, I want to explain to you where we started. In 2003, Dr. Agri was awarded the Nobel Prize for discovering aquaporin channels, which provided the substrate to the fact that brain tissue is completely permeable to water. And we knew that a wide variety of proteins are increased in CSF, in hydrocephalus. So we, at that time, hypothesized that large macromolecules can sufficiently create an osmotic gradient to encourage water flow into the ventricles. We basically hypothesized that water movement is secondary to macromolecular movement. And we tested the hypothesis by infusing hyperosmolar dextran into the ventricles of rats, two different kinds of molecules, 10 kilodalton and 40 kilodalton. And we showed that these rats got hydrocephalus without any obstruction to the CSF. We followed this up by looking at dose relationship to the amount of osmotic content to the degree of hydrocephalus. And this graph shows what we published in 2012, that degree of hydrocephalus was proportional to the amount of dextrans infused. Further, we had shown that the ventricles dilate within half an hour after injecting the hyperosmolar dextran, proving the osmotic gradient hypothesis that they're responsible for at least some or major part to get the ventricles full of water. When we looked at the dextrans that were labeled with FITC, or fluorescent label, we found that initially, within an hour, they're paravascular, and then they are taken up by the cells of the blood-brain barrier. Posed a model that takes the macromolecules from the ventricle into the paravascular spaces of the brain and subsequently transported into the blood vessel. And we wanted to show if macromolecules are responsible for fluid influx into the ventricles, then it should be delayed in hydrocephalus. So we used a 7 Tesla magnet to study two models of hydrocephalus, both obstructive and communicative, using kaolin model, and compared it to normal. What we did was 4 scans a minute and 80 scans over 20 minutes, with the first 2 being normal. And we calculated the ion-labeled dextran and R2 star value that determines how many milligrams or many micrograms of dextran there is in the ventricle. And we looked at the area under the curve and determined half-lives when you inject a single bolus of ion-tagged dextran. And you can see here, the top panel is the control where the T-half is 7 minutes, and the bottom panels show both hydrocephalic groups had T-half of 20 minutes, consistent with what we had hypothesized. So we showed that we published this research in 2018 in Brain Research. We showed that there is a delay in transport of macromolecules out of the ventricles and accumulation of injected dextran in the perivascular space in hydrocephalus. efflux transporters are a mechanism to eliminate xenobiotics, or things that don't belong into the body, out of the brain into the blood. And these efflux transporters are ubiquitous, including the blood-brain barrier. We were interested in P-glycoprotein because HTX rat, which is familiar to most researchers in hydrocephalus, has been shown to have decreased P-glycoprotein expression. So we conducted some experiments to see if P-glycoprotein expression determines the presence and degree of hydrocephalus. In which case, knockout of the P-glycoprotein, you shut off the vacuum cleaner, there is more garbage, will result in hydrocephalus. And overexpression should protect the rat from hydrocephalus. So we used a intraventricular hemorrhage model, used autologous blood, 130 microliter, in control rats, and compared it to a group that was P-glycoprotein inhibited, which is the MDR1A knockout, and group that was overexpressed, PGP, which is the MRP2 knockout. So we scanned the animals before the procedure, 5, 10, and 15 days after inducing hydrocephalus. And we calculated the half-life of the red fluorescent dextran that I showed you already. This graph shows the ventricular volume changes. So the green, so the pre-induction ventricular volume was taken to be as 0, and we looked at the increase in volume subsequently in the 5, 10, and 15-day scans. As you can see, the orange bars, they have statistically significant increase in the ventricular volume. They are MDR1A knockout rats, which are the P-glycoprotein poorly expressed or non-expressed. The MRP2 knockout rats had a little bit of protection, but still doesn't completely resolve the hydrocephalus. When you look at the T-half, or the clearance, the normal was 7 minutes. Normal with intraventricular hemorrhage was 14 minutes. And there is further increase in T-half in MDR1A knockout, which is the P-glycoprotein not expressed. But the overexpressed ones comes closer to the original normal level. So this inspired us to look at the clinical data to see if P-glycoprotein medications that we use commonly, do they have any effect on patients with hydrocephalus? So we used our EPIC, which is the electronic medical record system, over the last 10 years. Patients who are adults with hydrocephalus. We looked at people who are exposed for at least a month to selected known P-glycoprotein medications, which consists of both inhibitors and inducers, and compared them to people who are not exposed for any of these medications. This was a retrospective study. And these are the list of medications. There were many inhibitors and many inducers. What we found was that we had 3,006 unexposed patients in the data set. We had 142 who were exposed to inducers, and about 1,440 who were exposed to inhibitors. The statistically significant value was between the inhibitor exposure and the normal, and this was 0.0001. And the relative risk was 3.2 times for the use of inhibitors compared to normal or inducers. Of course, there are a lot of limitations with a retrospective study, but a relative risk increase of 3.2 is very concerning in terms of not recognizing the use of these medications in patients with hydrocephalus. So in concluding, we think that clinical data that we have corresponds to experimental data that macromolecular transport out of the ventricle is dependent on efflux transporter function. There are many efflux transporters, and I want to say it out here, and we're not sure that P-glycoprotein is the only one, but they're definitely a major part. This is the first study that raises concern over commonly used medications such as erythromycin, which is given commonly in kids to treat poor gastric intake, verapamil, which is the commonly used antihypertensive, omeprazole, and statins that can increase the risk of hydrocephalus. Future studies are in progress in our institute to determine whether some individuals are prone for hydrocephalus, in addition to confirming the role of efflux transporter modifiers in hydrocephalus. These are my acknowledgements, and thank you.
Thank you very much, Dr. Krishnamurthy, for this intriguing presentation. I would like to invite our discussants. We have got Dr. George Jallo, whom most of you know, a doyen of pediatric neurosurgery, Hydrocephalus. He's at All Children's Johns Hopkins Hospital in St. Petersburg, Florida. And we also have Dr. Pragnesh Bhatt. He's a senior neurosurgery consultant at the Aberdeen Royal Infirmary. Dr. Jallo, may I please, first of all, invite you to give your thoughts on the presentation and questions for Dr. Satish Krishnamurthy. Thank you.
Thank you, Naren. And that was an excellent presentation. The question I had was regarding the subarachnoid hemorrhage or the interventricular hemorrhage group. It appeared that there was a delay of about double to 14 minutes in terms of the clearance.
Mm-hmm. Yes.
And was there a specific volume of blood? Or did I miss that? How much blood was in the ventricle before you saw that delay?
Oh, the experimental data, this is what you're referring to.
Yes.
The experimental data was a fixed volume of 130 microliters.
Okay.
And this is not subarachnoid hemorrhage model. This is just an intraventricular hemorrhage. So it's not clinical data.
Okay. Now, is there a set, and why did you choose 130 microliters? Was there a reason for that volume that was chosen, or?
Yeah. So we chose the 130 microliter volume because we wanted to see hydrocephalus within the time frame of our 15 days. So we calibrated the amount of hydrocephalus, amount of hemorrhage in the ventricle based on how much hydrocephalus we got within the 15 days time period in normal animals.
Okay.
Llewellyn, do you have any questions, Llewellyn?
No. I agree with George. It was an excellent presentation. So just thanks for that.
Thank you.
Thank you
very much, Dr. Krishnamurthy. If you have any questions later on in the proceedings, please post your questions in the chat box. Thank you very much, Dr. Krishnamurthy.